In this section, we're going to talk about how the body is able to repair and heal damage to tissues. Repair is initiated by inflammation and by inflammatory mediators like cytokines, which are released from inflammatory cells. It involves one of two processes. One is regeneration. Normal tissue can grow to replace that tissue that was lost by damage or by inflammation. Or, alternatively, that lost tissue can be replaced by fibroblasts and collagen, forming a scar. Now, whether you regenerate or whether you form scars depends upon the presence or absence of stem cells. If stem cells are present, then those stem cells can divide and regenerate the tissue with normal tissue. If you don't have any stem cells, either because you're in a post-mitotic tissue where there are no stem cells, or because the stem cells were destroyed, then regeneration can't happen. And so in that case, repair has to occur by fibrosis. Now the repair process starts with the destruction and removal of the dead or damaged or injured tissue. And this occurs with neutrophils, which come in and digest the material, and macrophages, which then phagocytose, take it up and remove it. Then there's an influx of what we call granulation tissue. And this is a proliferation of capillaries, which bring blood and inflammatory cells and fibroblasts, which migrate and proliferate in the area, and you get a deposition of the extracellular matrix. And then you get regeneration of tissue or a scar. Now, understanding the cell cycle helps to understand this regenerative process. There's really three types of tissue. One is tissue that has cells that regenerate in perpetuity. They're constantly regenerating. And these are things like the skin or the GI tract or the hematopoietic system, where the cells are constantly being turned over and regenerated. These are tissues where, if damaged, that you can replace the lost tissue by regeneration. There's other tissues that have stem cells that are quiescent in the G0 phase of the cell cycle. And these are cells that can divide only if they're stimulated to leave G0 and enter the cell cycle again. These are things like hepatocytes and endothelium and renal tubular cells, which are able to regenerate only under specific circumstances. Then there are other tissues in which the cells do not divide. There are no stem cells. They're completely post-mitotic. And these are things like neurons and cardiac myocytes. If those cells are damaged, they cannot regenerate and they have to be replaced by fibrosis. Now, the stimulation of this fibrosis or repair process occurs with the interaction with cytokines and other mediators with cell surface receptors. Things like tyrosine kinase or 7-transmembrane G-protein coupled receptors or cytokine-type receptors. And these transduce signals into the cell and lead to activation of transcription factors and generation of proteins which lead to repair. Now, some of the growth factors and growth factor receptors which are involved in the repair process are listed here. Platelet-derived growth factors are produced by a lot of cells, but especially by platelets. These attract and cause fibroblasts and smooth muscle cells to proliferate in the repair process. Epidermal growth factor is a progression factor which causes the endothelial cells to divide and fibroblasts to divide and proliferate. Fibroblast growth factor promotes the synthesis of extracellular matrix proteins, stimulates the fibroblasts to produce collagen and other extracellular matrix proteins, and also attracts fibroblasts and endothelial cells for fibrosis and for angiogenesis. Transforming growth factor has two parts. Transforming growth factor alpha is like epidermal growth factor and functions essentially the same. Transforming growth factor beta is a growth inhibitor, and it regulates or inhibits the repair process. VEGF or VEGF, vascular endothelial growth factor, stimulates angiogenesis and the formation of granulation tissue, which contributes to repair. Now, scars occur when the damaged area is replaced by connective tissue scar, and this includes the migration of fibroblasts and proliferation of fibroblasts in the area, a deposition of extracellular matrix, including, most importantly, collagen, and that causes the formation of a scar. Now, scars can form in one of two ways. There can be healing by primary intention or healing by secondary intention. Healing by primary intention occurs when the edges of the wound are closely approximated. They're close to each other, for example, in a simple laceration. And this results in a minimal scar. And I'll show you how that happens in a minute. Healing by secondary intention is where there's a large wound and the edges of the wound are not close together. So this requires the formation of granulation tissue in that cavity, and eventually the contraction of myofibroblasts to contract that scar and decrease its size. And that's shown in the schematic here. Healing by primary intention is shown with a very small wound where the edges are closely approximated. You get neutrophils and clot, you get infiltration of small amounts of granulation tissue with fibroblasts, which repair it with scar, and you get complete repair of the overlying epithelium. Healing by secondary intention requires much more time and more granulation tissue, influx of more fibroblasts, and the replacement of this open cavity with that tissue. Then you get a proliferation of myofibroblasts with contractile activity, which have to contract that scar down, and you get the formation of a much larger scar, as indicated here. Now, things that can delay or complicate healing are listed below. Anytime you have retention of debris, especially if it's foreign debris, that can cause a delay in healing. If there's impaired circulation in individuals, for example, with atherosclerotic disease, where you can't get proper influx of inflammatory cells, that can delay healing. Persistent infection, where there's a persistence of the acute inflammation and not a conversion to the chronic and more reparative inflammation, can cause a delay. Metabolic disorders like diabetes contribute to this both through impaired circulation and also persistent infection. And nutritional factors, where you have an absence of something like vitamin C or some factor which prevents normal healing, will also cause a delay. Complications of delay are dehiscence and ulceration. Dehiscence is where you have a primary close of a wound, which then subsequently opens up under stress, and that can cause complications and difficult healing. Ulceration is where you get secondary infection and the formation of an ulcer, and that complicates this as well. You can also get the formation of a contraction. This especially occurs in healing by secondary intention, where you get such contraction of the underlying tissue that you lose mobility of that tissue. Now, in order to understand healing, you really need to understand something about the extracellular matrix. So we're going to talk about that in some detail. The extracellular matrix is everything that's outside and between cells, and it's a locally secreted network of structural molecules which serves as the framework for the cellular parts of our tissues. It consists of an interstitial matrix, which is fibrillar collagen, proteoglycans, hyaluronic acids, which fill the extracellular space, and the basement membrane, which connects the cells to that interstitial matrix. And this includes things like collagen type 4 and laminins. Here's a schematic of what that looks like. Here's an epithelium. This is the cellular part of the tissue. There are integrins and a basement membrane then, which holds that epithelium together and attaches it to the underlying extracellular matrix, which consists of fibroblasts and the proteins which are around the fibroblasts, the interstitial matrix of collagen, elastin, proteoglycan, etc. So let's talk about collagen specifically. Collagen is really the workhorse of the extracellular matrix. As you learn in biochemistry, but we'll review here, collagen is a triple helix of 3 polypeptide chains that have a unique tripeptide repeat. Every third amino acid in that protein is a glycine, and that results in a unique helical form which creates long collagen chains. This is called procollagen, and the formation of this procollagen helix requires vitamin C, the vitamin C dependent formation of hydroxyproline within collagen. This procollagen is secreted from the cell and is cross-linked. Multiple procollagen molecules are cross-linked together to form collagen fibrils. And this collagen fibril formation requires the formation of hydroxylysine molecules. And that's indicated here. Here's the endoplasmic reticulum and Golgi apparatus in which the collagen is translated, synthesized, and the helical procollagen is formed. That is then secreted from the cell, and the procollagen molecules are modified and cross-linked together to form collagen fibrils. There are 2 main types of collagen. There are the fibrillar types of collagen, which are types 1, 2, 3, 5, and 9, which form fibrils, especially in the extracellular matrix. And then there's the basement membrane type collagen, which is responsible for creating the basement membrane and attaching to the cellular contents. Different types of collagen have different functions. Type 1 collagen is the collagen that you see in bone and cartilage and soft tissues like the skin. Type 2 you see in cartilage. Types 3 and 4 are in blood vessels and in skin. And again, as we mentioned before, type 4 is found in basement membranes. Now remember that vitamin C is a required cofactor for that prolyl hydroxylase. So, and hydroxyproline is required for the proper conformation of the collagen, procollagen fibers. If you lack vitamin C, you get defective formation of collagen, and that results in the disease that we call scurvy. In scurvy, you get hemorrhage, you get joint space bleeding, and you get bone disease in children because they can't, their vessels lose strength and they're easy to break, and they can't properly form their bones, which have a collagen matrix to them. And so that's a severe disease in children. In adults, mostly what you get is hemorrhage, again because of inefficient reinforcement of the vessels by collagen. And you also get healing defects because wounds don't get the proper influx of properly structured collagen, and so you get a defect in healing. Here's an example, just a schematic of how that happens. There's the poor vessel support, which leads in bleeding from the skin, the periosteum, and the gums. And then there's the other effects that we talked about, inadequate synthesis of osteoided bones and impaired wound healing. Now you can also get defects in collagen that are caused by excess production of collagen. Now this is the formation of a keloid. This is overactive wound healing resulting from the excess production of type 3 collagen. African Americans in particular are genetically predisposed to the formation of keloids. And this can be so overactive that it produces large tumor-like scars, especially in places like the earlobes, the fat, neck, sternum, and forearms, as is shown in the picture on the right. Now, there are also some genetic defects in collagen. One of these is Ehlers-Danlos syndrome. Ehlers-Danlos syndrome is a very heterogeneous constellation of defects in fibrillar collagen synthesis or structure. Because it's heterogeneous, it can be inherited in an autosomal dominant, autosomal recessive, or X-linked fashion. And it gives clinical manifestations of collagen defects. The skin is hyperextensible, it's fragile and very vulnerable to trauma. It doesn't heal very well. The joints may be hypermobile because of defective formation of tendons and ligaments. The bones may be deformed because of defective bone formation. And the collagen fibers lack adequate tensile strength. And that leads to kyphoscoliosis, particularly in the subtype that's caused by lack of lysyl hydroxylase. You get vascular problems like ecchymoses and things like that in the defect in the collagen 3A gene. You get arthrochalasia and dermosparaxis type. This is defect in conversion of type 1 procollagen to collagen. And then the classical type, which is type 5 collagen in particular. Here's a picture of what that hyperextensible skin looks like. Now, another collagen defect is osteogenesis imperfecta. And this is particular autosomal dominant defect in the synthesis of type 1 collagen. The clinical features of this, while heterogeneous, are usually some combination of brittle bones leading to multiple fractures, blue sclera because of decreased collagen content of the sclera, and so they become translucent. They can have a sensorineural hearing defect due to abnormalities in the bones of the middle ear, and also dental abnormalities caused by abnormal formation of teeth. Here's a picture of what a baby with osteogenesis imperfecta looks like. You can see that there are numerous fractures and osteopenia, and they get accordion-like shortening of the limbs, as you can see, especially in the femur and in the arm bones here. Another collagen defect is Alport syndrome. This is an X-linked mutation in the alpha-5 chain of type 4 collagen, and this results in the thinning and splitting of basement membranes. Remember, the type 4 collagen is the collagen that we see strengthening basement membranes. What happens in this particular disease is you get defects in the basement membranes in the kidney tubules, in the nerves of the ear, and in the eye. And so they get renal failure, nerve deafness, and eye disorders. So Alport syndrome is a constellation of those three things. Now, another important component of the extracellular matrix are elastic fibers. And these are important because they allow recoil of tissues when they're deformed. And the elastic fibers are made up of two components. There are microfibrils, and there's elastin. And these two things together make up the elastic fibers. Now, there's a disease called Marfan syndrome, which is an autosomal dominant defect in the fibrillin 1 gene. And this results in abnormal formation of elastic fibers in the extracellular matrix. And the main thing that you see in this disease are skeletal abnormalities, dislocation of the lens, and cardiovascular lesions. Now, the cardiovascular lesions especially occur because of the elastic fibers which are found in large arteries in your body. And so what happens in Marfan syndrome is you get cystic medianecrosis, the loss of the tunica media, leading to aortic dissection, which can be fatal in these patients. So here's a clinical vignette associated with that. A 7-year-old male presents with diminished visual acuity, and his uncle died of a ruptured aortic aneurysm. And so you can see the two things there. Aortic aneurysm, you think of Marfan syndrome. Diminished visual acuity, you think of lens dislocation, which is common in Marfan syndrome. On physical examination, he has long extremities, long, slender fingers, and his lenses are delocated. He has an aortic diastolic murmur, and that's one of the defects, the cardiac defects or vascular defects associated with this disease. Here's what they typically look like. Long and skinny, long fingers. You can see kyphoscoliosis, that's a skeletal abnormality. They may have pectus excavatum, which is a sternal abnormality, and then the other features that we talked about. Another component of the extracellular matrix are proteoglycans. And these are proteins that have a very large carbohydrate component to them. We learned a little bit about these in biochemistry. So you have a core protein and you have polysaccharides extending from that surface. And these are important because they regulate the structure of connective tissues. Common proteoglycans include things like heparan sulfate, chondroitin sulfate, and dermatan sulfate. Hyaluronic acid is a specific proteoglycan, which is a polysaccharide that binds to water to create a hydrated gel. And that's really important, for example, in the cushioning effect of cartilage, for example. Now, mucopolysaccharidoses are a group of diseases that result from a deficiency in the lysosomal enzymes which are involved in the degradation of mucopolysaccharides. And again, we talked about this at some length in biochemistry. What happens then is you get accumulation of these mucopolysaccharides in lysosomes and cells, leading to cell death. So these come in different types. Type 1 is Hurler syndrome, a defect in alpha-L iduronidase. It's autosomal recessive and results in clouded cornea and other defects. It's a very severe form of the disease. Type 2 is Hunter syndrome, iduronate sulfatase deficiency. This is X-linked. It doesn't have the corneal clouding, and it's much more, it's milder. More details about the clinical features of these are available in the biochemistry lecture. But the common pathologic features of this are accumulations of mucopolysaccharides in mononuclear phagocytic cells, macrophages of the liver, spleen, lymph nodes, bone marrow, and brain. And these get distended with vacuoles which stain positive for the PAS stain. PAS stain highlights carbohydrates. And so what you see then is you see the cells distended with these mucopolysaccharides which have a large carbohydrate component to them. The onset of this is in early childhood. They have coarse facial features, clouding of the cornea, especially in type 1 Hurler syndrome, joint stiffness, mental retardation, and you can diagnose it by increased urinary excretion of these mucopolysaccharides. And this ends this section of